Hello people, this is Dr. Muskaan this side, and today I'm going to discuss very beautiful case. It is all about gastric perforation, and the story of this case is very interesting. So here is 44-year-old male who has came to ER at 9:45 p.m. with chief complaints of pain in abdomen since morning. On arrival, ABCS was done. That was airway, breathing, circulation, and sensorium. Airway was patent. Breathing airway was patent. That means there were no signs of airway obstruction. What are the signs of airway obstruction? Choking. Patient is holding his neck and saying, "I'm not feeling like breathing." So yeah, dysphagia, dysphonia, stridor. So these are the signs of airway obstruction. So that was not present in the patient. So airway was patent. Next is breathing. On breathing assessment, we check respiratory rate and SpO2. That was also normal in this patient. Respiratory rate was 18 per minute. SpO2 was 94% on room air. On circulation assessment, pulse rate was 80 per minute. Blood pressure was 144 by 98 mmHg. That means pulse rate was normal because normal lies between 60 to 100 per minute, and BP was increased. That means hypertension is there. Sensorium was alert. E4 V5 M6. That means Glasgow Coma Score was 15 by 15. E4 V5 M6 means eye was open spontaneously, verbal response was oriented, and motor response, he was obeying commands. HOPI, patient was apparently asymptomatic 8 hours back when he developed pain in abdomen, which was insidious on onset, gradually progressive in nature, associated with obstipation, low grade fever, nausea. Okay, it was aggravated on doing daily chores, released on taking painkillers and rest. Past history, no similar complaints in past. There was no history of type 2 diabetes mellitus, hypertension, TB contact, epilepsy, asthma, cardiovascular disease, or any other comorbidity. There was no history of past there's no past surgical history. Personal history, patient was on mixed diet, bowel and bladder habits are normal, obstipation uh, was also there. Obstipation का मतलब क्या होता है? That he is not able to pass the flatus, pass the gas. He has addiction of tobacco, bidi, one pack, and occasional drinker also from past 20 years. Sleep is adequate. On general examination, decubitus, patient was conscious, oriented to time, place, and person. He was cooperative also. Vitals all were normal except blood pressure. That means he was hypertensive. Pickle was negative. What is pickle? Parallel icterus, clubbing, cyanosis, lymphadenopathy, and edema. They were all negative. Systemic examination of abdomen was done. Why abdomen? Because patient came with chief complaint of pain in abdomen. So on inspection, of course, in systemic examination, what we do? Inspection, palpation, percussion, and auscultation. Inspection, all quadrants move equally with respiration. There was no scars, there was no sinus, there was no dilated veins, umbilicus was centrally placed and inverted, there was no visible peristalsis. On palpation, rigidity was present, guarding was present, diffuse tenderness was present, mild distension was present, exaggerated bowel sounds were present, and abdominal girth was 84 centimeter. On auscultation, bowel sounds were exaggerated at left hypochondric region. Rectal examination was also performed. There were no skin tag, no fissure, no fistula. Anal tin was normal. Ballooning was present. No bogging. No finger stain with stool. So it was feeling like it is surgical abdomen. So of course, exploratory laparotomy was done, and indications were abdominal distension. Why they thought of that? Abdominal distension was there, obstipation was there, because after coming to hospital also, and there was time of 10 hours, he has not passed the flatus. Guarding and rigidity was there. On chest checks and ultrasound, it came out to be normal, but CT scan was showing some findings and there was a doubt. Then again x-ray was done, and in that x-ray we have appreciated air under diaphragm, so we decided to open the abdomen thinking it is a surgical abdomen. When abdomen was explored, perforation was found near duodenum, so suturing was done, omentum patch was placed, modified gram patch repair, and again then suturing was done. Okay, So at last, the diagnosis is of course gastric perforation, and the reason we think it is a gastric perforation is gastritis, means there's increased acid reflux. Why this case was interesting? Because to find out the reason of gastric perforation was a kick. There was no road traffic accident, there was no history that kuch hua hai, there was a sudden pain. So after surgery, patient was shifted to ICU in view of pneumoperitoneum. ABG shows respiratory acidosis. On day 3 in ICU, there was fever of 101 degrees Fahrenheit. Patient was intubated and extubated. Now, after discussing this case with you, I want to make you go through with the topic of peptic ulcer perforation and pneumoperitoneum once. A little bit theory part. I hope you will find it interesting after seeing that this case is there. So let's start. Duodenal ulcer was the perforation of the duodenal ulcer leading to chemical peritonitis, leading to which is due to acid exposure. Now, clinical features, we will find peritonitis. There will be abdominal pain, guarding, rigidity, fever, tachycardia, and shock, which were all present in this patient. Investigation, gas in the diaphragm signifies hollow viscous perforation. That was also there in this patient. But I want to make you notice that initial X-ray, initial ultrasound was normal. In there, then CT scan was being done, that was showing a little bit finding. Then there was a doubt coming in the mind, thinking that it might be surgical abdomen. Again, X-ray was done, and in that X-ray we came to know that there was gas under diaphragm. So it felt like it is a surgical abdomen, but on initial part it was nothing. Management, how the management was done: IV fluids, antibiotics, pain management, exploratory laparotomy with gram patch repair. Triple tube technique can be done, which is more than, if the perforation is more than 2.5 to 3 centimeter. Now I want to make you go through Johnson classification of gastric ulcer, which have 1, 2, 3, 4, 5. One is ulcer along the lesser curvature, which is most common. 2 is pre-pyloric or duodenal ulcer. 3 is only pre-pyloric ulcer. Now 2 and 3 makes it vagotomy because of PPI. 4th is ulcer in the body of the stomach, bleeding. Left gastric artery is the reason of the bleeding. And 5th is diffuse NSAID ulcer. So in our case, this we find it out to be grade 2 gastric ulcer according to the Johnson classification, which is pre-pyloric and duodenal ulcer. What further complications can be there in this case were of, again, there can be perforation and bleeding. Further, we can also find out renal vein sign, renal veil, VEIL veil sign, collection and air around right kidney, and Valentino syndrome can also be there, which is collection and air around right kidney. Now I also want to discuss a little bit about pneumoperitoneum. What is pneumoperitoneum? When surgery is done, port are created with carbon dioxide. Now there are physiological effects of pneumoperitoneum. One is peritoneal stretching, which leads to vagal stimulation and sinus bradycardia. Second is diaphragm is pushed up, which leads to increase intrathoracic volume, due to which there is decrease in tidal volume, TLC, vital capacity, and residual capacity, FRC. Now pressure on renal arteries is there as a physiological effect of pneumoperitoneum. When there is increased intra-abdominal pressure, there is IVC gets compressed, which decreases the venous return, which increases the when venous return is decreased, there is compensatory increase in heart rate. Why? Because cardiac output is equal to stroke volume into heart rate. So when stroke volume will be decreased, there will be decreased cardiac output. Second, there will be prolonged surgery because carbon dioxide get absorbed and causes metabolic acidosis. Sodium retention can be there, and there can be increased intracranial tension. So this is all about pneumoperitoneum. I really enjoyed studying this case because it was a fun game for me to find out the reason of gastric perforation. I hope you have also enjoyed the history of this patient. That's all. Dr. Muskan Bansal is signing off now.